Good afternoon. My name is Isa Houwing, and I'm a family medicine doctor and associate professor in the Department of Family Medicine at Mayo Clinic here in Rochester, Minnesota. And I'm leading research and education in the field of genetics and pharmacogenetics in primary care practice. I would like to welcome you to the Rochester Center for Individualized Medicine Grand Rounds. The SIM Grand Rounds lecture series is designed to highlight the latest in scientific discovery and innovation and demonstrate how individualized medicine is being translated into practice to meet current and future patient needs. It is a great honor and my pleasure to introduce today's presenter, Dr. Muin Khoury. Dr. Khoury is the founding director of the CDC's Office of Public Health Genomics. The office was formed in 1997 to assess the impact of advances in human genetics and the Human Genome Project on public health and disease prevention. For more than 25 years, the CDC's Office of Public Health Genomics has served as the national focus for integrating genomics into public health research and programs for disease prevention and health promotion. Dr. Khoury has developed a number of successful ongoing national and international initiatives to translate advances in genomics and related technologies to recommendations and actions that improve health and prevent disease throughout the life stages. Dr. Khoury received his Bachelor of Science degree in Biology and Chemistry from the American University of Beirut, Lebanon, and his medical degree and pediatrics training from the same institution. He received a PhD in human genetics, genetic epidemiology, and training in medical genetics from Johns Hopkins University. Dr. Khoury is board certified in medical genetics. This month, an article written by Drs. Chandler and Goddard was published in the journal Public Health Genomics, and it speaks about advancing genomic implementation from discovery to public health benefit. In the couple of decades since the initial release of the human genome sequence, an explosion of genomic applications at all stages of the continuum of care have progressed. We no longer singularly focus on what genomic applications could improve health outcomes. Our research agenda has shifted to how we can ensure that those applications are available and optimally used to benefit population health. We recognize that optimizing care does not necessarily mean offering more services to all. The potential for overdiagnosis and overtreatment of those who may not benefit must also be taken into account. Both as a primary care clinician, of course, but also researcher and educator in this field, this topic is very close to my heart. And it shows the complexity also of this topic, but also the opportunities we are facing to improve healthcare and hopefully for all of our patients. Today's presentation is called From Public Health Genomics to Precision Public Health, a 25-year journey. During this talk, Dr. Khoury will define the fields of public health genomics and the field of precision public health and use specific examples to illustrate it. He will also discuss the near-term opportunities and challenges for genomics and big data to improve population health. Throughout this time, please use the Q&A in Zoom to submit your questions for Dr. Khoury. We have planned time for Q&A at the end of this session. Please now join me in welcoming Dr. Muin Khoury.
Thank you, Isa, so much. I appreciate the warm welcome. Let me see if I can share my slides. Well, good afternoon, everyone. I appreciate the opportunity to speak at the Mayo Clinic. I don't remember the last time I was there, but must have been at least 10 years ago or more. So what I'd like to do in the next 45 minutes or so is take you on a journey. It happens to be the journey of two fields, public health genomics and precision public health, which were directly related to the Human Genome Project and now more advances in technology. But it also happens to be my own personal journey because I've been the director of this office at CDC for more than 25 years. And I'm becoming a little bit sentimental towards the end of my career because I'm retiring at the end of this calendar year. So this is, for me, kind of a sort of looking back, looking forward. There's so much to unpack, and I don't want to waste too much time. Last year, we celebrated our 25th anniversary. These are the people who worked with me for some of them all of the years, and we had a big virtual party. So Before we get into public health genomics and precision public health, those of you in the clinical world sometimes don't know what public health does. I mean, you have an idea what we do in public health because of COVID and because of outbreak investigations or cancer surveillance, et cetera, et cetera. But to put the context of public health in juxtaposed with genomics and big data and new technology, we have to realize that the US public health system is kind of fragmented. Some of us live in government agencies, like myself. I'm in a federal agency, but there are state agencies, local public health agencies. But all of the actors, according to the Institute of Medicine back from the 80s, including the healthcare delivery system, and the communities and the media and academia and everybody is working together to assure the conditions for population health. So it's about looking at health from a population perspective, not as a one-on-one clinical or patient perspective. And what we do in public health, we call them the 10 essential services. Equity and disparities is at the center of this wheel. You know, we do assessment of the health of populations, whether it's a state or a county or a jurisdiction. And we develop policies and guidelines, and then we try to make sure that these things are implemented and evaluated at the population level. When we get to genomics, I'll give you some examples. So it's important to realize, and this is not the first time you all hear this, that healthcare alone does not guarantee improved population health. This is a recent paper by Blumenthal based on the Commonwealth recent analysis of the health system performance compared to healthcare spending in 10 developed countries, the US, of course, leading the pack. It doesn't take a rocket science to figure out that the US is an outlier. We spend too much money on healthcare. Some may claim we have the best and the most important discoveries, and that could lead to improved healthcare and outcomes. But our performance based on this article or this study of 70 measures of health systems performance, including outcomes, is an outlier. We have less, but we spend more. Our life expectancy, and this is since the pandemic, is 4 years behind these other countries. So what does it take? And really, these two figures are from two separate papers. One is Tom Frieden, New England Journal of Medicine. He was the CDC director at that time. And this is a more recent paper in which Mandy Cohen, who's the current CDC director, talked about the partnership between medicine and public health here as a team sport in this recent paper, and reflected to the health impact pyramid. In other words, tackling health problems is not just at the top of the pyramid, meaning doing clinical interventions or counseling and education, but also going down, developing policies, and then tackling socioeconomic factors. And then point of fact, the further down you tackle a health problem through the pyramid, the higher the impact. In other words, if you deal with one patient, you've improved the health of one patient. But if you deal with a community, then you improve the whole community. So this is one reason where public health and medicine should be working together. So coming back to the Human Genome Project. So as medicine became more and more genomic in the last 25, 30 years, public health had to develop the adequate response to that as a partnership to ensure that genomic medicine will succeed at the population level. So I don't have to define to you what genomic medicine is, about using the genetic information to advance care and prevention and diagnosis. What we do in public health, and this is from our Bellagio report, this is an international meeting in public health genomics 20 years ago. It's a field that is involved with the effective and responsible translation of genomics into population health benefits. So this is in a nutshell what the field is about. But let's go back and look at the promise of the Genome Project. This is a paper by Francis Collins, who at the time in 1999 was the director of the Human Genome Project. And he predicted that in the year 2010, that we will be having this kind of scenario in clinical medicine, a a hypothetical 20-year-old man named John, it's from his paper, that he will undergo a battery of genetic tests, maybe the whole genome, and it will be found at higher and lower risks of different diseases for which personalized or more precision interventions could be developed. Now, notice we are in 2024. This is still not a reality, although we're moving in that direction, but it takes a long way to get to this point. Some of them are discoveries, some of them are evaluations, like epidemiological studies, and some of them are implementation. So we are moving in that direction, but we're not there yet. So I've been writing about this through the office and working with many partners to try to impart the notion that the success of genomic medicine does require public health. First of all, we focus on prevention. So to the extent that genetic information can be used in preventing disease, not just diagnosing, we focus on those. We focus on implementation. We focus on measuring impact at the population level. We are very much sticklers on evidence-based practice, and we want to assure both the performance, the lab quality, and the delivery of the right services. We want an educated provider set and general public, and we want to make sure that health disparities are front and centers. So as Isa mentioned, we have been 25 years or now more in this business. We're a small office that has been working across the public health, CDC, many partners to enable and promote public health efforts to try to integrate this knowledge. And what guides us, has been guiding us, are what I call the 3 I's: identify, inform, and integrate. So we work with all kinds of programs, and I'll give you examples: the cancer program, the heart disease program, diabetes. Try to identify what works, what doesn't work in genomics. We inform and communicate, and then try to help them integrate into their programs that do not use genomics as a starting point. This is a brief timeline. I'm not going to give you the whole shebang, but 5 years ago, we wrote this paper, a 20-year journey. So now we are 5 years later. This paper actually summarizes our journey for 20 years, and there is more that happened since 2017. But basically, national leadership, national conferences, developing competencies for the public health workforce. We funded schools of public health. We funded state health departments for pilot projects. We focused on evidence-based applications. I'll give you examples of those. Throughout, we've tried to educate the public and providers on family health history as the low-hanging fruit of public health genomics. And we moved into a tier-based classification of guidelines. I'll give you examples. And then the last 4 years, we focused a bit on COVID, new initiative, and then implementation science. So some examples as we go. So just for us to situate our journey here, that the bench to bedside model, which is, sort of is the undercurrent of discovery to application, is what has been driving genomics so far, that first phase of translation. But what we deal with in healthcare and public health is what I call the road less traveled. And we wrote a paper along those lines more than 10 years ago. So not only we need to have applications at the bedside like drugs and tests, but we need to evaluate them so that the right guideline can be developed and then apply implementation science to make sure that these things are integrated into practice, and then continue the evaluation at the population level, and then back and forth with knowledge integration. So this is, many people call this sort of the second valley of death. This is a recent analysis by the National Academy of Medicine. This is the first valley of death, but I think we're making progress in all of this. When we first wrote that paper to evaluate the literature in beyond the T1 phase, we found that less than 2% of what's published in genomics is that second phase of translation. That has improved a little bit, but still we need more of those kinds of studies to evaluate implementation and outcomes. And to give you an example that along the lines, as we keep in mind health equity and disparities, as you move through this translation continuum, that health equity issues tend to be compounded from one phase to another. As you discover things and you use the wrong population subsets, in this case GWAS, you end up with applications that may or may not be relevant to subsets of the population. Now, I think there is more variety and inclusion in these initial studies, but this paper was from 2018. And then you start evaluating the discoveries as generic tests, and you end up, let's say in this case, when they evaluated cardiomyopathy, genetic testing, you end up with more inconclusive results in underrepresented and minority groups. Why? Because they were not included in the initial research that led to the discoveries. And then when you start implementing things in that third phase of translation, still, even if you've done the best studies, you've done the best evaluation, if you don't have access to care, if you don't have the right people coming in to get them, you end up with low referral rates, let's say in this case, for universal colorectal cancer screening, for Lynch syndrome and genetic testing. So throughout this continuum, public health research or the various disciplines from epidemiology to communication, behavioral science have a role to play. Colleen McBride is the editor of Public Health Genomics. She has recently written a paper, an editorial, explaining the value of public health sciences throughout this continuum. Of course, implementation science was mentioned. Over the last couple of years, we partnered with NIH, primarily NCI, to put on a series of courses and activities that was culminated in a two-day course last September as a training institute for dissemination and implementation research in genomics using the CIPHER consolidated framework for implementation research. You can look it up. That is probably about 1 or 2 hours worth of a talk by itself. Now, one of the important things that I think our group championed over the years is this EGAP initiative, which is evidence-based genomic medicine. So EGAP stands for Evaluation of Genomic Applications in Practice and Prevention. For 10 years, we formed an external panel similar to the US Preventive Services Task Force, independent of CDC, independent of the government, to review and do systematic analysis of potential genomic applications. And they wrote the methodologies. They used 10 to 15 case studies, and then disbanded in 2014. The most important relevance of EGAP is that many of their methodologies have been adopted by professional organizations across, not just, various disease groups, but across the board. And one of the things that they did was lay out the foundation and differences between clinical validity of a test versus clinical utility. The clinical validity starts with, depending on how you use the test, as diagnostic or screening or prevention, it starts with associations between genotypes and outcomes. And you can have the best clinically valid test, but it may not change the health outcomes. It may lead to more harms than benefits. So I think having a more in-depth evaluation was the purpose of EGAP. And they highlighted over 10 years how unready or not ready at the time most of genomic medicine was. One of the early recommendations they made in 2009, which is still not implemented optimally in the population, is testing all new cases of colon cancer for Lynch syndrome. They found enough evidence. They wrote it up in 2009. The study I showed you earlier shows the gap, especially with the ethnic and minority groups. There is a gap in implementation of this guideline. Since they disbanded in 2014, our office continued with the tradition of using evidence-based classification. Some of you may have heard about CDC Tier 1 applications, and this is what we do. We review the literature, we review what all professional organizations put out, and those applications, genetic tests that are supported by evidence of clinical validity and utility, we have given them Tier 1 status. Newborn screening, I'll give you some examples. Tier 2 is when you have a clinical validity, but not enough data on clinical utility, usually insufficient evidence, but going along the way. Many pharmacogenomic tests are still here. Some people may argue on one or the other, but as a field, we're still mostly here. And tier 3 is no data or data more benefits than harms. I classified for a long time the whole field of personal or direct-to-consumer genetics as a tier 3. Some people vehemently disagree with us, but that's okay. We can have a dialogue on this. Now, newborn screening is the largest public health genomics program in the world. As we all know, it started long before we've had the Human Genome Project. And in the 60s, now over time, it has become more systematized. We have a panel that looks and makes recommendations across all states, a recommended uniform panel, more than 30 plus conditions, mostly genetic and metabolic conditions are there. And notice we pick up more than 10,000 babies, but that's over 4 million births every year. And now the advent of genome sequencing or next-gen sequencing is upending the whole newborn screening arena. We can discuss that if you want. And right now, our group is planning the next phase for what CDC should be doing in this area. It will continue long after I retire at the end of the year. So selected tier 1 applications in the adult world in 2012, when we did a strategic planning effort about 12 years ago, we wrote up this document that we searched and found there were 3 conditions, 2 cancers and 1 heart disease related, and later added hereditary hemochromatosis and hypertrophic cardiomyopathy to the list. We're dealing with numbers much, much bigger than newborn screening. So, we have evidence that implementation of existing guidelines are not happening, and therefore that we need more of a partnership between healthcare and public health to ensure that cancers related to these conditions and heart disease related to FH is optimally prevented. So let me review what these are. So 2 cancer syndromes, BRCA1 and 2, and now more genes added. Lynch syndrome with mismatch repair genes. Okay, you know, if you look at the numbers, they account for the minority of these cancers, breast, ovarian cancer, and colorectal and endometrial cancer. So from my public health perspective, people in public health always saying, why should we focus on these rare conditions? Now, numerically though, per year, if we are able to find or prevent these numbers of cases in the country, that just these 2 conditions is 3 times more than what we can do with newborn screening. I'm not saying newborn screening is not important, but I'm saying that there is more opportunities for prevention throughout the lifespan. So for breast cancer, for a while now, we've known that from the US Preventive Service Task Force that screening, identifying family history associated with BRCA counseling and testing has been sort of standard of care. And now more genes are being added. When one of the early projects, as I mentioned earlier, we funded states to do pilot projects. Michigan was one of those states in which they undergone strategic planning in genetics and public health and the cancer plan. This was in the 2005 to 10 range. And as a result of the pilot funding, we were able to increase the number of counseled women and tested women in the state of Michigan during that period of time over the whole population. Now, on a national level, this is from an article in the MMWR that we wrote a few years back. We were able to document the increase in genetic testing, BRCA testing in the whole US in the 5-year process, and this is still ongoing. We have newer data that shows increase, but notice that there is still a rural-urban difference in uptake. Notice the bump here, what happened in 2012, the bump for both rural and urban area. This is when the Affordable Care Act went into effect, and the Affordable Care Act sort of started funding or covering services that are approved by the US Preventive Service Task Force. So hence the uptake. And also there was a Supreme Court decision invalidating the Myriad patent in 2012, which also coincidentally led to a decrease in the prices around BRCA testing over the last 10 years. FH is another prototype tier 1 application. There's about 1 million plus people in the US with this genetic condition, autosomal dominant. 1 in 250 people. There are evidence-based guidelines for finding people with FH. They end up with high LDL cholesterol. They're not your garden variety polygenic hypercholesterolemia. They need intensive cholesterol testing and cascade testing in relatives. By the way, the other two as well, because they're also autosomal dominant, both Lynch syndrome and hereditary breast ovarian cancers. So there are missed opportunities, partnerships. This is, by the way, the Marta bus in Atlanta was driving one time. We partnered with the FH Foundation. They have been doing public education campaigns about heart attacks, especially early heart attacks in life, and thinking about FH. We developed both studies and educational opportunities to educate providers and the general public that the high risk of heart disease and premature heart disease can be reduced. And but at a national level, when we looked at NHANES data, only half of the people with FH are taking statins, and only 16% of them are taking high intensity statins. So these are a few things that providers can do at this level. Now, cascading is very, very important, but it's complicated. This is a paper that I'm co-authoring with Josh Knowles from Stanford back in 2017 in JAMA, in which we talked about the process of cascade screening. It's a complicated process, and this is a hypothetical pedigree in which the proband, who happens to be here, what the recommendations say, if you find somebody with FH, then you cascade to first-degree relatives, and then if they're negative, you stop the cascade. If they're positive, then you cascade to the next first-degree relative. So we were, hypothetically showing that this pedigree, extended pedigrees, goes into multiple states, multiple healthcare systems, and, cascade screening, unless it's done as a national public health effort, like some countries did. Earlier in the Netherlands, for example, they did a national cascade screening effort. It's very hard to do it from an individual healthcare entity. So just to move beyond the tier 1, tier 2, polygenic as an example. Polygenic risk scores are promising, but yet problematic from many perspectives. And just want to use an example of a potentially low-hanging fruit in polygenic risk score. This paper is now old, but the idea is still the same. For any disease, you can develop a polygenic risk score. In this case, for breast cancer, using, and I forget how many SNPs they used in this study, to stratify the 10-year absolute risk of breast cancer in women with or without family history. And if you assume that, say, the average person, you start mammography at the age of 45 or 50, and basically people with higher percentiles of polygenic risk scores will have that same risk earlier, 10-year earlier, and especially if they have family history. So family history is still important even without the polygenic risk scores. So the combination of them is both. So there is now an interest and lots of studies that are evaluating whether or not, polygenic risk scores could be added to, sort of personalized breast cancer risk calculators to see whether or not when to start mammography. So this is just an example of this. Of course, I want to continue the journey with rare diseases. Newborn screening is an example of rare disease, but there are up to 10,000 rare diseases out there, potentially affecting 10% of the population. More and more rare disease genetics is making its way to the fore, diagnosing sick newborns in the NICUs, for example, for rare conditions. There is the potential to do gene therapy and the diagnostic odysseys. This field is actually exploding, has exploded in the last few years. Potential for gene therapy, still not there yet, but we're making some a lot of progress in rare diseases. Now, for those other conditions which were not ready, we've advocated and collaborated with other groups, NIH and others, to advocate for a learning health systems, let's say biobanks, such as the ones you may have in Mayo and Geisinger and Kaiser and others, UK Biobank, in which you do both research and practice. And the way we recommended in this paper is that if you're doing sequencing on people for research purposes, you return you do the tier 1 genes, you return them to participants, and then you assess how best to return them and look at the outcomes. The tier 2, then you may be able to do more clinical utility studies, perhaps RCTs, return versus not return. And the tier 3, you just keep them in the bank and you do your observational analyses until such time where things move across categories. So these are not set in stones. You know, we hope as much of the genome will make it into tier 1, meaning ready for implementation and practice in not too distant future. So where I hope will be ending in the next 10 years, and there is an active dialogue. Remember, I mentioned newborn screening, but there are people, including myself, thinking about population-based DNA screening across the lifespan. So my friend Jim Evans, who retired from UNC a few years back, we wrote this paper, We Screen Newborns, Don't We? Realizing the promise of public health genomics. So before we start any DNA screening or any screening in general, we all remember the WHO Wilson and Junger criteria for when are things relevant to population screening. Many organizations like the American College of Medical Genetics and Genomics are now looking at whether or not there could be a set of genes that everybody should be screened for, you know, especially for the pathogenic variants in these genes. And on that short list are the CDC Tier 1 applications for obviously, but right now, there are no population screening recommendations, just cascading or family-based screening criteria. So stay tuned, this topic will hopefully mature with more studies in the next decade. So I think I spent 35 minutes talking about public health genomics, and I want to switch gear to precision public health in the next few minutes. And happy, by the way, to answer any questions in the Q&A session. So in the last 10 years, roughly, genomic medicine has matured and has evolved to include other things. Big data now led to what people call personalized medicine or precision medicine. Excuse me, sorry. So as we go beyond genes to include big data, we are now able to integrate all of these things together to look at gene-environment interactions and other things to be able to derive and deliver more precision in our therapeutic and preventive strategies. So public health genomics has evolved over the last few years to become more precision public health. So what is it exactly? So I have been blessed to be in the public health sector where, for the most part, public health does not like the word precision public health because they think it's personalized public health. I've debated my friend Sandro Galea, was the dean of the Boston University School of Public Health, about what is, whether or not precision medicine can actually improve population health. Most public health professionals have a narrow view of precision public health, meaning the application of precision medicine or personalized medicine at the population level. By the way, this, I make fun of my own field. During the pandemic, I started noticing the word precision everywhere, including my neighbor's lawn. Somebody called precision lawn care. I mean, who would want, precision tune up? Don't you want to have your car tuned up with more precision? Obviously. So this is a debate we had a few years ago, was published in JAMA. We asked the question, will precision medicine improve population health? Sandro Galea said no, I said yes. And we had a YouTube 1-hour discussion about this. And his notion is that no, because and maybe it's definitional in nature, he thinks precision medicine is genomic medicine. I think about precision medicine as more data at the population level that includes social, environmental, and other determinants. And so precision public health is this emerging field that uses all this data, similar to what we did for genes, effective and responsible translation of all the data to deliver more precision in our public health activities. Let me elaborate a little bit more. If precision medicine is about delivering the right intervention to the right patient at the right time, our perspective at the population level is delivering the right intervention at the right population at the right time. I'm not talking about individuals, but populations and population subgroups. And so the question is, which has been a hypothesis, can we conduct our essential public health services with more precision? Can we have more precision in the way we measure population health problems? I'll give you some example. Can we have more precision in developing targeted interventions or programs? Can we have more precision in delivering the right interventions? And the answer is yes, yes, and yes. But more work to be done. Nature Medicine published a whole series of papers earlier this year on precision health, essentially. And they had one paper on precision public health. And Megan Roberts and the co-authors of the paper quoted, and as we consider areas of precision public health advancement, we find that precision public health is really fundamentally rooted in the basic concepts of public health, with the three essential public health functions and public health services. In other words, it's an evolution of what public health does. What do we mean by that? So if we characterize the health of populations, which starts with individual by place, person, and time. For those of you who studied epidemiology, this is like epidemiology 101. Who gets a disease, where, and well, over what period of time. We now have more opportunities, more tools to measure these parameters at place, person, and time. We have subtypes of a disease using biomarkers. We have genetics to measure susceptibility. We can use social media to characterize people. We can we go from small area analysis to using geographic information systems, environmental data, all of these, forget omics for a while. I mean, the whole field of omics. And we have the capability through, smart apps and phones to measure blood pressures and heart rates, not only when you go to your physician once a year or once every 5 years, but continuously over time. The challenge is, and people using that information in the clinic is one set of challenge, but at the population level, it's even more challenging to do it. But the stage is set to use them. In 2016, I wrote this paper on the 3 priorities for precision public health as we move forward. One, focusing on prevention. Let the treatment, let precision medicine deal with the one-on-one in the clinic. Focus on prevention. Modernizing public health data, surveillance, epidemiology, and information systems. Because if we don't have those basic tools that integrate all these data together, then we have no chance of getting more precision. Improving early detection of pathogens and infectious disease outbreaks. That's really the low-hanging fruit of precision public health, not the human genome, but the pathogen genome. And with this as an early example, in the mid-2010, there was CDC integrated pathogen genomics into its surveillance efforts. So this listeria outbreaks, they used to do pulse gel electrophoresis in state labs, and they switched to whole genome sequencing. By the time they integrated whole genome sequencing, they were able to link more cases with food, solve more outbreaks. The median number of cases per cluster decreased. The number of outbreaks solved increased. So there was a more precision in applying surveillance to solve an outbreak. Of course, we all know about COVID and COVID variants, and genomic surveillance became became an essential precision tool during the pandemic to not only find out what's going on at the population level, but to tailor vaccines to different variants. And this is data from the data tracker, the COVID tracker over time, 21, 22, 23, 24. Notice that the variants changed, the vaccines changed, etc. during that time. And now, last but not least, we are able to have more precision in surveillance by adding genomics and sequencing and other tools to wastewater surveillance. Basically, during the pandemic, they were tracking where hotspots in COVID long before people went for individual testing in clinics or in health departments through the sewage weeks before showing up in individual tests in clinic. Now, of course, I'm a human geneticist, so polygenic risk scores was big during the pandemic, and I've never seen as much such a short period of time. Within a few months, actually a couple of months, 50,000 COVID patients were put together by the COVID Host Genetics Initiative from different countries, found 15 hits in the polygenome, developed polygenic risk scores. The question is, what is the clinical relevance of the polygenic risk score? I just wanted to incidentally give you on the environmental side, what we've done at CDC in terms of looking at COVID hotspots by the Social Vulnerability Index, or SVI. Otherwise, I call it fondly the polysocial risk score. So you can develop a score based on household composition, racial ethnic groups, household type, and transportation, and show that in the highest quartile, you are at higher risk of COVID. So wouldn't it be nice to combine polygenic risk scores and polysocial risk scores and intervene in that using all the data that comes to that is at hand. Now, of course, the Gates Foundation got into the Act of Precision Public Health. They published a paper in 2016. They hosted a Precision Public Health Summit that I was at. They basically, this is their own definition of it. They talked about the importance of data collection, especially around the world, and I will spare you that. So with the last few minutes, I'm going to end with a few thoughts. I mean, this is obviously such an overview that I couldn't go in depth in any of the points I raised, but just to take you on the journey with me. So as I said earlier, people are in public health. They don't like precision public health because they think it's personalized medicine. They think we are abandoning our mission of enhancing population well-being, the core that public health precision implies concern only with individuals. I hope I dispelled that notion. And actually, Richard Horton, the editor of The Lancet, came to our defense in this piece that he wrote a few years ago. He said, I think these people are conflating apples and oranges. Precision public health, put at its simplest, is about using the best available data to target more effectively and efficiently interventions of all kinds to those most in need. So this is precision public health, and in a way, there's nothing new about this. Public health has always tried to focus on high-risk groups. It's not now, just have more tools to measure who's high risk, who's not, that we can try to use in that intervention. But our approach, our patient is the whole population, and we're trying to improve the health of that population. But more data doesn't mean more precision. 10 years ago, I wrote this paper in Science in which kind of set the stage for, at least for my own way of thinking at the time, that when big data meets public health, the caption here is that human well-being could benefit from large-scale data if large-scale noise is minimized. And this is really, at the end of the day, is sort of the pros and cons of using all the data, because we still have the same problems of selection, confounding, missing data, measurement errors, ecological fallacies. For those of you who do epidemiology, this is sort of what's drilled in us day in and day out. There are complex analytical methods that are now evolving. And of course, the promise of AI is now thinking that, well, we don't need any of this stuff. The machine will keep learning and relearning, but the machine can only give you what you put into it. If the data is selected, confounded, biased, there will be problem in the output. So as a result, we may or may not deal with health equity. We may increase health disparities. So it needs scientific rigor and evaluation similar to any other tools and technologies. And we need to address the ethical, legal, and social issues around privacy, stigmatization, etc. So we're entering a brave new world here that we're just beginning to scratch the surface. And in closing, I want to use the example of obesity to show you how the new tools are beginning to be used. I mean, obesity is a problem in the US, and we can now predict or help predict obesity from data from the micro to the macro. So using this paper by Amit Kara from Broad Institute looked at childhood polygenic risk scores have a good predictive ability of obesity later on, trajectory from birth to adulthood. If you look in the medical record, electronic health records, you can classify with high, differentiation, ROCs, who's obese, who's not. So from publicly available data, but the one that really caught my eye is this study. Now, a few years earlier, the caption is "Artificial Intelligence Spots Obesity from Space." So this study looked at 4 urban areas, Seattle, Los Angeles. They extracted built environmental information from space images using convolutional neural network. They correlated the data. So they had the physical characteristics of neighborhoods, parks, highways, etc. So this is all from space. And then they had the data that the health departments have collected using the behavioral risk factor surveillance and asking people about height and weight. And they correlated observed and expected obesity rates based on artificial intelligence versus what people collect from surveys. And I don't have to tell you, the observed and expected are right on target. So we are able to do so much, even without talking to people in predicting where the hotspots are. But the question, so this is all validity type studies, but the utility of this information, can we actually use it to improve the health of the population? So this is my last slide. I want to leave at least 10 minutes for discussion. That as medicine incorporated genomics and now is becoming more precise, public health, which is your partner in dealing with health problems, we have to work side by side to improve the health of the population, not just the patients you see in the clinic. And we need both of these disciplines. And as we become more precise in our measurements of health, we need both fields to implement these new technologies and ensure health equity. And we need more evaluation, more evidence. And for me, as I get ready to retire from CDC right now, I can tell you that the next 25 years are going to be so much more exciting than the last 25 years. And I wish I can start my career all over as a result. And I hope we can get more young people interested in this area of precision public health and public health genomics. So with that, I'm going to end the slideshow.
Well, thank you so much, Dr. Khoury, for this wonderful presentation and overview of everything that's been going on. Of course, I had heard of some of these, and I had read a lot of these articles already, and it's very, very inspirational to what I've been up to of these last couple, well, almost decades. So I was just wondering, I'm very happy that you were saying the next 25 years are going to be more exciting than the last 25 years, especially because I recently came over to the US and looking at that New England Journal of Medicine paper, and it's showing us that the performance of healthcare in the US is not that great.
Yeah.
I'm just wondering about your view on how can we get there? How can we get all this knowledge into public health and primary care practice?
So this question is very hard to crack because it's at the core issue of the intersection of science, policy, politics, and the US is I'm an immigrant. I've been here about 44 years, and it continues to baffle me sometimes how the best country in the world, technologically and discovery-wise and innovation, can have such a picture painted. This article, the one slide I showed from that article tells the story, and that story is not new. And what I'm afraid of right now is that these new technological advances can lead to more disparities, rather than lifting everyone along the way, then we'll leave some people behind. So until we deal with the sort of underlying, remember the base of the pyramid with Tom Frieden's talk. I mean, that base, socioeconomic factors at the top. Yeah, I mean, if you can catch a patient in your clinic and give them the right intervention, you will improve, you'll save them, etc. But to get from the bottom of the pyramid to the top of the pyramid is a coordinated societal perspective. The problem in the US is that it's not one country. You have 50 states, each with their own approach to health, to policy, politics. So newborn screening was heterogeneous for many years, for example, until this advisory committee started recommending a universal panel for newborn screening. And even within a state, you have counties, you have different healthcare systems. So what, the Mayo ecosystem is one thing, and you can improve the health of your population, okay, people who come to you. Not everybody comes to you. Somebody goes somewhere else. So it is tough not to crack, and we're not going to do it in this seminar. I mean, the best minds have to get together and deal with both the resource issues, allocations, policies, and politics and ethics. And I'll leave it at that. And I'm happy to discuss it more, but I think you put your finger on the pulse.
Mm-hmm. Yeah. An anonymous attendee, and I don't know whether this person wants to come forward, is saying it is hard to imagine the potential of precision public health since to this day 90% of treatment decisions in the clinic or policy level are not personalized per se, but rather doing the same thing for every patient: blood pressure control, weight management, improve environment, social determinants, food supply, tobacco, taxes, etc. In other words, if we implement effective and non-personalized interventions, we are more likely to improve the health of the entire population, shifting the entire population to lower risk.
Right.
Jeffrey Rose's concept of sick individuals or sick populations. Yeah.
Right. So there is this debate in public health: sick individuals versus sick populations. Okay. I've even written a paper on Jeffrey Rose a while back in my youth. So even if you read Jeffrey Rose, he was not saying, so let's take cholesterol for a minute. There are 100 million people with high cholesterol in the US, roughly. There's only 1.5 million people with familial hypercholesterolemia. Even if you find all the 1.5 million and you treat them, then you still have not dealt with the cholesterol problem in the US population. So this, the high-risk approach, which FH represents, is not going to solve the cholesterol problem in the US. So we still need to find 100 million people with high cholesterol and treat them. So, and to me, if that also begs for more precision in the way we find these 100 million people, because right now, most of these people are not being diagnosed, they're not being optimally treated. So as we move towards more precision, we not only can capture the 1.5 million people with FH, but we can do good for everyone. So the objective of public health is still the same. It's just using more tools in our toolbox to be able to find everyone and treat the people who need the intervention, whether or not they have a genetic syndrome or whether or not they have a polygenic multifactorial hypercholesterolemia. So I identify, I mean, this is what I hear in my own home here in public health. Because when I talk to people who say, forget the high-risk approach, we have a bigger fish to fry. Okay, we have so many obese people in the US population. Why are we going after the rare ones with syndromes? I say, yeah, but this one-size-fits-all approach hasn't really worked. We keep getting more and more obese. We keep getting more and more health problems. So we need, even Jeffrey Rose, if you read his papers, recommended both approaches to work as appropriate and as driven by evidence. So he wasn't picking one over the other.
Yeah, I totally agree with you. But I think it also reflects my idea, at least, that primary care is not getting the credit it deserves here in the US. Primary care and public health, so to say. Because we see people before they get sick. you know, where we have to apply this precision medicine initiatives, basically. Yeah. I don't see any other questions right now. Perhaps somebody in the audience wants to ask coming forward still. So I'm wondering how we should engage the patients, because we haven't really talked about that.
Which patient are you talking about?
Any patient.
Any random
When we
patient?
think about the public health field, of course, we think about every patient because it applies to all.
You know, to me, I don't think of people as patients. We're all patients at one point or another. I think we need to have a prepared general public. And I didn't talk about our family history initiative. You probably know more about this than anybody, that, you know, it's very important that people take charge of their health. And even before they see physicians, collect their family history, because you have no time to spend with people collecting the family history. You never know what you're going to find. So by empowering people to know more about themselves, about their relatives, then when they become patients, or if they become patients, then that information may become relevant to their care. But it's hard. I mean, I can tell you one thing, and this is kind of, I say it with as more or less as a joke, but it's not really a joke. I have one daughter who is a primary care family doc in Seattle. And I asked her one time, do you take family history or do you discuss family history? And she said to me, and I'm paraphrasing, are you kidding me? I don't have time to do anything, because she deals with, and she works in an underserved clinic near the Seattle airport. And it's very hard to get traction when you have to see 20, 25 patients every day as part of primary care. So primary care is part of the solution, but the patients and providers and all of us have to kind of be invested in our own health. And it's very hard. It's very hard to do it, whether it's personalized, precision. I think we need to do the kinds of studies that academicians do to showcase if and when new tools. I mean, everybody has a phone. Everybody has a smartphone. Can we use that information, for nudging, for better follow-up, for better control of blood pressure, etc. There are studies being done right and left, and only time and scientific rigor will tell us whether or not all these technology-driven interventions can improve the status quo.
Mm-hmm. Well, thank you so much, Dr. Khoury. We have to end this wonderful discussion and this wonderful grand rounds. Thank you so much to all the attendees and to Sim for hosting this. And we hope to see you back next time.
Thank you very much for the invitation. Take care, everybody.